Sorry, Gerald, Gerald, can you make me record in Spanish, not French? Abubakar will take French.
Welcome everyone to the launching of the second edition of the Water and Sanitation for Health Facility Improvement Tool, known as WashFit 2.0. My name is John Brogan, and I'm an advisor with Helvetas and the Swiss Water and Sanitation Consortium. And it's my privilege to join you today for this event organized by the World Health Organization and UNICEF. There's a wonderful lineup of speakers who will reveal key features of the second edition of WashFit, and that includes representatives of the Ministries of Health of Uganda and Indonesia to share their WashFit implementation experiences. For simultaneous translation, you can choose a language by clicking the interpretation button at the bottom right corner and then choose either French, Spanish, or English. Today, we'll be having at least one contribution in French, so it's best to already select English if that's needed. Please introduce yourselves in the chat. I see several of you are already doing that. Let us know with whom you are with and where you're joining us from. During the presentations, if you have questions, please also post them in the chat. We'll have a short time at the end to get to the questions, and if for some reason we can't get to all the questions, we'll find a way to answer those after the webinar. So the making of this new edition of WashFit has been an ongoing process for over a year, led by Arabella Hayter with a core group of WHO and UNICEF colleagues. And they've reached out to many of us who've been active in over 40 countries, working on WashFit since it was first launched in 2018. In the past 2 years, the dual crises of COVID-19 and climate change, plus declining security situations in many countries, have brought to light the need for WASH in healthcare facilities, for safe and quality care and healthy communities. For those of you who are new to WashFit, welcome. WashFit is a risk-based management tool for healthcare facilities. It's used by a WashFit team. Usually this is members of a facility medical staff, management committee members, and community leaders. It covers water, sanitation, hand hygiene, waste management, cleaning, and selected aspects of workforce, energy, and facility management. It's a participatory methodology, and it's done to make continuous improvements that enhance infection prevention and control. And for those of us who are already using WashFit, this new edition does not mean that we have to start over. It's the approach and the WashFit standards are the same between the two versions. So we just keep going and we integrate what we need from this new version as we need it. This second edition, it responds to user requests for more guidance and focus on additional themes related to climate resilience, environmental sustainability, and gender and equity. In this edition, we benefit from an updated list of indicators, from a training manual, and the specific insights and guidance on how to sustain safely managed water, sanitation, and waste services and hygiene practices. As always, it's a flexible tool. We can take apart these materials and use them, adapt them as we need for our training, for our assessment and monitoring in our own projects. For me, the most impactful experience of using WashFit is what happens that's unexpected. Like in Mali, where a WashFit team of a healthcare facility and a municipality decided that upgrading the sanitation infrastructure was needed. So they fully funded all of the investment needed for that, including electricity, menstrual health and hygiene management facilities, and disability access. And in Ethiopia, where a 24-year-old woman, herself a member of the WashFit team, became a leader on that WashFit team. And she helped to convince the community and the local authorities that investment in waste treatment infrastructure was needed. And all this only a few months after she gave birth to her own child in that same facility. So there are many stories like this. WashFit is making a difference. Today, Maggie Montgomery and Julie Storr from WHO will start us off by sharing about this second edition. And then we'll hear some WashFit experiences from the field. Dr. Anas Maruf from the Ministry of Health, Government of Indonesia, and Mr. Dennis Okello from the Ministry of Health, Government of Uganda will be sharing their WashFit experiences, as well as Abubakar Ballo from Terezom in Mali. And finally, Kellyanne Naylor from UNICEF will share some insights and talk about the way forward. So again, welcome. We are a diverse and dedicated community of practice. And now I'm delighted to hand over to Maggie and Julie to talk to us about this second edition of WashFit.
Perfect. Thank you, John. And it's wonderful to see so many familiar names, but also many new names. And hearing those last inspirational antidotes from Mali and Ethiopia really brought a smile to my face, because we do a lot on WASH and healthcare facilities, but the WashFit to me is the most interesting because it's in the facility. It's where we're actually making those improvements and hopefully making a difference, not only in the lives of the patients, but all of those working in facilities. So next slide. So I'm just going to give a very quick overview of what's in version 2.0, but I just wanted to start off by saying, and as John already communicated, it's still the same WashFit, right? So if you're using WashFit, and if you don't know about WashFit, you can also start today with the second version. So it's an incremental improvement process based upon the work that had already been done for over a decade now on water safety planning, and more recently sanitation safety planning. And it's really meant to be a support mechanism for facilities and countries that are working on quality improvement. So it also goes through that same QI approach about bringing together a team, assessing the situation, developing an improvement plan that's based on risk as well as resources, and then continually monitoring and improving that plan to make sure not only that the improvements are sustained, but that new improvements can also be done. We know there are a lot of important impacts that WashFit can lead to. And it's not just about better wash services. And obviously that's really important, especially to those of you who are water engineers. But there's so many other aspects about improved staff morale and performance, around increased care seeking. Obviously, it facilitates being able to carry out good infection prevention control practices. So thinking about all of those slew of benefits, I think is important, not only in what motivates those teams, but in how we're really trying to focus the work. Next slide. So there's 7 domains. Now, 5 are the traditional domains of water, sanitation, waste management, hand hygiene, and cleaning. And these are all based on existing WHO guidance. And they also include the same indicators that the WHO UNICEF Joint Monitoring Program is doing. So WashFit goes much beyond JMP because it's really trying to work to implement all of our standards, but it does include those basic indicators as well. In this new version, we've also included a lot more from energy environment. And it's really exciting to see that the work in terms of how we electrify healthcare facilities and some of those same basic needs is coming together with the work on water sanitation, all under the much broader umbrella of climate and environment. And there's also more information in this one as well around the management and workforce, because we recognize that most facilities don't have enough people to do all the jobs, right? So how do we, in the most efficient way, empower and equip the staff that are there, and try to also make sure that more resources are obtained to make sure that staff like cleaning and waste workers, which aren't traditionally seen under the health workforce umbrella, are properly resourced. Next slide. I've already mentioned the improvement cycle. You can take a look at it here. It's 5 steps, and those steps are iterative. So it's a way to continually to go back to check to improve. Next slide. So as I've already mentioned, what else is new in the second edition? Well, there's a lot more guidance, and that guidance is based on groups like all of you who are already implementing the tool. And it's really exciting that we have both Indonesia and Uganda who have already started implementing aspects around gender, around climate, who are going to speak a bit more on that. But we've given a little more guidance on how the tool can be adapted, both to look at more rudimentary or even emergency facilities. We know that there's a lot more emergencies in the world today, unfortunately, than there were when the tool was first developed, but also to look at those middle income and higher income settings, right? Where issues around water scarcity, issues around AMR spread are very important. Throughout the tool, we now have indicators, we have case studies, we have training material to look at climate and the environment, as well as gender and equity. And these aspects, we're finding they're non-negotiable, right? They're not just add-ons. It's how do we make sure we are putting in services that are resilient in terms of climate shocks, but also aren't adding already to the detrimental effects, whether it be through excess waste production, or how energy is generated, or how water may or may not be treated. There's also more on looking at pathogen risk and spread through water and sanitation. And we know that safely managed services are very critical in communities, and we know the same in healthcare facilities. So facilities aren't connected to safe, reliable pipe treated water supplies or safely managed sewage systems. What could facilities feasibly do to make sure that the water they have can be treated and is safe, and also that the wastewater that they're creating is not adding an additional pathogen burden to the community surrounding that facility? And as I mentioned, the second version has the same incremental approach and is based on the same guidance. I will say that since we published the first version, WHO has come out with the sanitation health guidelines. And so we've really benefited from drawing upon those guidelines, which are the newest set within the WHO WASH guidelines. Next. Okay, I'm going to speed up here because I know we're short for time, but there is a whole package of resources. So we have the guide, which is now online. You can download it. If you don't have the link, we'll share it in the chat. We also have a number of fact sheets that look at things like climate, safe plumbing, gender. Again, those are all online, and those can even serve as standalone if you want to focus on just one specific aspect. There's a whole set of training slides that are interactive and based on adult learning, which will be online very soon, as well as a WashFit manual for trainers, which is also coming. So stay tuned. But there is already a lot, both on our knowledge portal as well as on the WHO site. Next slide. So I'm not going to go into detail, but one thing that we've also done in this version is to summarize very succinctly what are the various indicators. And here I just threw up the indicators for water, but there's a lot more in there about, whether or not there's been breakdowns, whether or not there's been sufficient quantity for different types of users, what kind of backup storage is in place. To make sure that at all times there can be a reliable and safe source of water. Next slide. In terms of risk, we got a lot of feedback on how the original version was looking at risk and just how users were thinking about risk. And I think that often there was a lot of confusion about marking everything as high risk or nothing as high risk. And at the end of the day, just wanting to do something. So really focusing on those small doable actions. We've tried to keep it really simple, but also concrete, and that there's just two things to look at: the severity of the risk to the users, as well as the environment and climate, as well as the likelihood of occurrence. And there's just two examples here. One is on there's no functioning waste treatment. So this obviously is high risk, because it means all that infectious waste could be contaminating the rest of the waste, but also be putting users and the community at risk. And the second is looking at the safe fecal waste management, and how this is probably a slightly lesser risk, but obviously still really important to think about how that could be improved through improving septic tanks or through improving the safe emptying of existing tanks. Next slide. In terms of costs in resources, there's also more information this time. We just published 2 weeks ago now our price tag analysis of wash and waste services in healthcare facilities in the least developed countries. And we were really able to draw upon this analysis, which is based on primary costing data from those 47 least developed countries, to provide a lot more guidance on what are some really immediate low cost interventions, like repairing leaking pipes and taps, to putting in or fixing stormwater drains, all the way to longer term and higher cost items, all of course with that idea of climate resilience in mind. So if you're going to put in water tanks, make sure they're raised so they're protected against floods. Next slide. Gender, and we're going to hear a lot more from Indonesia because they've done a lot of really pioneering, innovative work on gender. But just to say, we've learned a lot, and I personally have learned a lot, that it's not just about having women on your team. It's not just about checking to see, if there's a toilet that has facilities for menstrual management. And while those things are important, we've also recognize that there's a lot of issues around power dynamics, the fact that in healthcare facilities, most of the decision makers and the doctors are men, and the nurses and the cleaners are women, but also about making sure that the services that women need, in particular, for example, showers after giving birth, are safe and private, and can really facilitate the needs of certain groups that often have not been prioritized. So you can check out that fact sheet and look forward to hearing from others on how they're adapting this. Next slide. So WASH Fit in Action, there's a lot going on out there. This just gives a quick snapshot of the countries that we know and have, conveyed to us what they're doing. The ones in yellow are countries that have adapted WASH Fit as the national tool. And they might have called it something else, which is fantastic. But in our perspective, this is really great because it means that there's one common approach. There's one set of technology designs, but there's also then a growing group of organizations and countries that can really take a look to see, okay, we're implementing WASH Fit. What does it actually mean for the improvement in our WASH services? And what does it mean for how well we're doing to integrate this issue of WASH in healthcare facilities into health programs and budgets and monitoring and review. And I just want to give a big shout out to all the partners out there that are working on this. And it's really fantastic to have John Brogan leading us through the discussion today from Helvetas, but there's many others out there that have worked on the tool, and really thank you for all your efforts. Next slide. So as I mentioned, check out our knowledge portal because there was a bunch of updates made to it today to have all these materials there. And again, look forward to learning more and also to hearing what further needs you may have in terms of using and adapting WashFit to really make a difference in healthcare facilities. So thank you, and I'll hand it over to Julie.
Thank you, Maggie. We'll now spend a few moments providing an overview of the new training resources that accompany WashFit 2.0. So central to the WashFit methodology is training and incremental improvements. Maggie mentioned implementation of WashFit requires 6 preparatory steps at the national level, one of which focuses on national sensitization and training of trainers. And at the facility level, we have the 5 steps, the first of which involves establishing and training a WashFit team. So the purpose of this manual is that it outlines the information and the materials required to undertake training in line with WashFit 2.0. And this modular approach enables trainers to decide on the topics that are most useful to support delivery of targeted training at your local level. It aims to provide information to build capacity in a cadre of trainers, enabling them to prepare for, deliver, and evaluate WashFit training. And its target audience, the manual is for trainers who will be delivering the training. It's for those supporting delivery of training, people responsible for resource allocation, for example. It's for those involved in preparing training courses at the national or facility level. Next slide. So if we think about navigating the manual, it's got 3 sections. The preparing section in purple includes an outline of the usefulness of training needs assessments and local fact-finding missions. It includes a list of considerations related to the people required to run a successful training. It has a focus, importantly, on both face-to-face and virtual training, and it provides some country effort examples and some prompts to consider when addressing resources and budgets for training. The delivering section in the middle here provides an outline of all of the training modules, and it signposts you to an overview of each module. It signposts you to example training agendas, both face-to-face and virtual, to help prevent wheel reinvention, and these are based on real trainings that have taken place. Provides some additional prompts to consider as you start to deliver training, including adaptation, and it does also include the lessons that we've learned from many of you out there around the barriers and mitigations. And then this final section, the evaluating section, signposts to pre and post-test examples that can be used and adapted, and other evaluation forms. It has a mock-up of a certificate of completion. We know that many of you like to use these. And it addresses sustainability as well, and also a list of summary action checks. And I think it's important to say that we have a set of annexes where a really rich suite of resources live. There are 15 resources found in these annexes. I've mentioned some of them. You can see on the screen, it's the sample pre-post test. It's an outline of those 9 training modules, sample agenda, post-training action plan, and the list goes on. And again, importantly for this to help the user navigate the manual between different sections easily, there are many hyperlinks, so that you can just click, for example, here, you could click on delivering, it will take you just to that section. So if we go to the next slide, and here we are in the delivering section, and we have an outline of the modular approach. It introduces you to those WashFit training modules. And each of the modules listed on the screen is available as PowerPoint slides, as Maggie mentioned, with speaker notes and group exercises. And they can be downloaded from that WASH portal. As a minimum, we suggest the WashFit methodology module is recommended to be delivered. And then other modules may be delivered as necessary, informed by the local situation and assessments described in section 1, preparing. And we can't emphasize enough the key here is adaptation to local context. And I think just to say that it's probably useful to note that those who perhaps have never been involved in WashFit previously may find it useful to work through this manual in a linear fashion. Those of you who are at a more advanced stage, more mature stage, perhaps have already completed training and assessments, you may find the manual and its contents useful as a refresher, or to go directly to certain modules or associated resources to support your current work. So for illustration, let's take a quick look at the structure of each module by clicking on the climate resilience module. Next slide. So here, as you can see in the manual, we have a breakdown of each of the modules, and the formula that's used on the right is that follows the same approach for each module. So there's a table and it describes any pre-training preparation. It lists the learning objectives of that module. It indicates the length of time the module should take to deliver. It lists which languages the modules are available in. It provides a short summary of the module and each of its subsections, and a summary of how the module is constructed. And it also lists all of the supporting materials and resources available to be used and adapted. And finally, the table provides an instruction for group exercises where applicable. Next slide. So there we have it, a very rapid introduction to the manual. We look forward to your feedback on the utility of this manual, but in summary, the ultimate aim is that it supports and empowers you to deliver effective WashFit training. Thank you for your time.
Thanks, Maggie and Julie. These, just looking at them, these are great resources, not only for WashFit, but for anyone who wants to learn technical and practical aspects of implementing WASH in healthcare facilities. So now we're going to have an online poll. It's just one question. So considering your own experience and what what Maggie and Julie have shared, you see the poll has now been displayed. You can just see that question, and I'll read it for the benefit of the interpreters. Which of the following do you think are the most important for conducting a WashFit assessment and developing and implementing an improvement plan? So you can check off as many as you think are relevant based on your local context. So the poll is, let's just take 60 seconds and answer. If you're joining from your phone and the poll is not visible, you can use the chat box to participate. Just put whatever you feel is the most important. And as the poll is not offered in French and Spanish, you can also answer your choice in the chat box if you prefer. So again, that question is, which of the following do you think are the most important for conducting a WashFit assessment and developing and improving an improvement plan? So there's political support, financial material resources, human resources, civil society engagement, intersectoral collaboration, for example, with energy and climate and health, training, or something else that you feel is important. Please just drop it in the chat box. Okay, let's take 10 more seconds. Okay, let's close the poll. And here we have some results. So we can see that many scored very high, particularly financial and material resources are very important, as well as training. Those are the two highest. And then, well, gosh, they're all quite important. All of them have their own place and importance in this whole process. So depending on your context, you may need to focus more particular attention on one or the other, but they're all quite important. So now we're going to turn to our colleagues in the field to share their experience on using WashFit. So first, I'm pleased to invite Dr. Anas Maruf. He's the Director of Environmental Health with the Ministry of Health in Indonesia. And Dr. Maruf will be talking about progress on WASH in healthcare facilities through using WashFit. Dr. Maruf.
Thank you, John. Good morning, good afternoon, and good evening. It is a pleasure to be with you and share our Indonesian effort on strengthening WASH and mainstreaming gender equity, disability, and social inclusion or GETC in healthcare facilities in Indonesia. Next slide, please. I think that WASH in healthcare facilities is a fundamental prerequisite for improving health outcomes. We know all that the key driver of all government in the world is to be in a good position to meet the Sustainable Development Goals target by 2030, where WASH in healthcare facilities lies under SDG 6 and SDG 3. We also know that inadequate water, sanitation, and hygiene services place with health workers and patients, especially women and children, at a significant risk of infection and increased likelihood for mortality. To achieve that, there are some question marks of whether enough is being done at a very basic level at the healthcare facilities. Whether the WASH in services in healthcare facility are inclusive enough to ensure quality and no one left behind. Next slide, please. Recalling the World Health Assembly Resolution 70.7 Agenda, item 12.5 on WASH in healthcare facilities, Indonesia put effort in following the recommendation and improving WASH in healthcare facilities through some initiative. In 2020, MAOH has reported that progress towards the resolution of the World Health Assembly and committed to guide example on WASH in improvement, which focus on primary health centers, that is inclusive and resilience. Next slide, please. The slide shows that available and functional WASH in healthcare facilities is fundamental for patient safety and quality of care. With that understanding, Minister of Health has done a regular healthcare facilities research we call RIFASKES, Riset Fasilitas Kesehatan, which covers WASH component. In 2019, the data has shown that we need significant improvement in some areas, including water, cleaning, management, and healthcare waste management services. Especially during the COVID-19 pandemic, consistent application of WASH and waste management practices is essential to prevent transmission of COVID-19, especially in healthcare settings. Equal access of WASH for women and vulnerable groups need to be assured as an integral part of an upholding human right. Next slide, please. Minister of Health also has enacted a decree in 2019 on public health centers that highlight the requirement on inclusive WASH infrastructure, like including water, sanitation, and hand hygiene facilities access, lighting, and also waste management and safety. We conducted WASH fit, like training as virtual TOT training program. This training involved MOH staff from across directorate, UN agencies, developing partners, academia, and development partners. The training has initiated the agreed action plan that we use to improve the WASH service to be more responsive to gender and equity. Also, the challenge of climate change in the healthcare facilities. Next slide, please. The training of trainers paved the way to improve WASH in healthcare facilities through agreed milestones. This training also demonstrated that creating an enabling environment requires a multi-sectoral approach with partnership that work synergies to improve quality WASH services in healthcare facilities and therefore health for all. During the training, we also have identified that there are 3 areas that need to be strengthened. WASH Fit tools is very comprehensive tools that encompass the component of water, sanitation, hygiene, waste management, environmental cleaning, management, and energy. And we contextualize the tools to Indonesian context and pilot in selected districts. The second action is to develop the costed roadmap and continue with the implementation. As in the third phase, the efforts are mainly focused on information system and capacity building at the sub-national level for more sustained implementation. We target that all 10,000 primary health centers should be introduced to WASH Fit and adopt it as a base to develop their improvement and WASH planning and budgeting by 2024. Next slide, please. And how did we initiate to the milestone? In the process, we first review the indicators in the existing WASH and improve it to sensitize GERCI and include climate resiliency. In the tools, we included access to the menstrual hygiene facilities, personal protection equipment supplies that accommodate male and female's need, accessible access not only for the toilet structure, but also ensuring the privacy, cleanliness, and infrastructure design to reach the sanitation facility. And health promotion, materials that can be accessed by people with disability and older people. Next slide, please. This capturing show that best practice from the pilot sites. We developed the costed roadmap and guideline of WASH in primary health care. MOH and WHO led a series of virtual focus group discussion with several primary health cares, sanitarian, cleaning staff, health workers, also with civil society organization, development partners who work with WASH, women's rights, children's rights, and the right of the people with disabilities in different provinces in Indonesia, and with across directorates in MOH to gather perspective on the specific WASH need of women and vulnerable population in healthcare facilities. Next slide, please. In another side, for policy and guideline, MOH has also worked with WHO to draft costed roadmap for WASH in public health services. In this roadmap, there are 7 strategies for strengthening WASH health facilities, where the elements of GERCI and equity are used as the fundamental rationale of these strategies. The roadmap also depicts the national target for each WASH component. All the intervention in the strategy has projected costs that can imply the need of budget allocation that shall be planned from 2020 to 2030. Next slide, please. This slide shows that the infrastructure and facility are continuously improved after the healthcare workers assessing the risk and doing regular inspection. This includes the installation of hand washing station and monitoring of the quality and hand hygiene practices. Next slide. please. We also have the information system of medical waste management, we call SICLIM, managed by MOH since August 2021. The system accommodates data collection and analysis on the waste management process, such as waste segregation, storing, treatment, and transportation and disposal. MOH supported the system improvement to converge better data of public health centers and hospitals, both private and public, inform about COVID-19 waste generation, map waste management capacity and resources, status of mercury elimination from the health service, and waste weight assessment tools. The system is under finalization and we will be used national to assess environmental health officers in assessing the overall waste condition in their facilities. Next slide. I am pleased also to share you to take always from our initiative. In Indonesia, we have more than 10,000 healthcare centers. The implementation was services need sectoral collaboration between government and non-government sectors. In this activity, the development partners are very supportive to increase the awareness of GETSI at the community. The regular capacity building on waste and GETSI is important, as many of local staff did not aware on how the waste in healthcare facilities can contribute to the hospital-acquired infection. Thus, routine training on GETSI in waste for all relevant actors is important. We also learned that COVID-19 is a momentum to improve waste in health center facilities, and we need to be prepared for upcoming health threats through strengthening waste and waste management. During the pandemic, we have released significant technical guidelines on COVID waste management. And the last, involving vulnerable population in policy planning, implementation, and monitoring is possible and important. The last slide, please. Yeah. Lastly, allow me to share a famous quote: "There is nothing about us without us." It means that no policy or program shall be decided by which representative without the full and direct participation of the group members affected by that policy. This underscores the importance of the involvement of vulnerable groups in WASH in healthcare facilities. I end my presentation here, and once again, thank you for having me in this meeting. Thank you very much, John.
Thank you, Dr. Maruf. That resonates very strongly, that last quote. And thanks for this candid presentation on the journey of the Indonesian government to improve quality of WASH in healthcare facilities with a national target of 10,000 healthcare facilities. And for being a pioneer in contextualizing these indicators for gender, equality, disability, social inclusion, and environment. Next, we turn to Uganda. We're joined by Mr. Dennis Okello. Dennis Okello is a senior environmental health officer with the Ministry of Health, and he's here to share his experiences about implementing WashFit in the Omoro district. Mr. Okello, welcome.
Thank you, John. Thank you, Dr. Anas, for the good presentation you made. And thank you all other panelists. I'm Dennis Okello. I work with the Ministry of Health as John stated it. Next slide. Hello, next slide. Next slide. Yeah, I'm happy to tell you that you said regional health integration to enhance health services in the north. Actually, sub-region introduced WashFit in Omoro district. It was like a pilot project. And in the process, they trained health management team members. And after that, the health management team members trained health workers in 9 health facilities within Moro district. Out of the 24 health facilities that we have in Moro district. Moro district doesn't have a hospital. Then implementation of the wash fit was being done by health workers. Then it was the responsibility of the members of the district health management team to do the assessment. And this assessment was being done quarterly. And out of this assessment, we usually used to rank the facilities basing on their performance. To address some of the gaps, which was assessed and found within the facility, the project you said Rights North actually supported the health facilities with the IPC materials provision. They provided healthcare waste bins. They also supported the hand washing facilities. They provided detergents. They also provided the health facilities with the IEC materials and also training protocols, hand washing protocols, and some facilities also for management of waste bins. I mean, for management of healthcare wastes. Next slide. Next slide, please. Yeah, out of this intervention, which we started in 2018 up to 2021, we achieved the following, basing on our criteria for ranking of the facilities. This is for the 9 facilities which has been aggregated. So we found that wash indicators increased from 47% to 73% for the 9 health facilities. And then sanitation indicators also increased from 63% to 92%. Hygiene indicators increased from 49% to 94%. And then management also increased from 50% to 83%. We did a baseline before the intervention, and the baseline was showing those indicators which showed like 47, 63, 49, and 53. So we got, within 2 years, we got a very big change using this wash fit tool. Next slide. Next slide, please. Yeah, out of this intervention, we realized the following impact. One is that because this health facility, the 9 health facilities out of the 24 were very clean, and it attracted a number of mothers to come for deliveries, also to come for antenatal care, to come for postnatal care. So there was a great improvement in the indicators, which we usually report to the Ministry of Health as the ANC attendance and postnatal care attendance. Also, within those 9 facilities which we implemented the wash fit guideline in, there were poor management of waste in terms of littering some part of the compound, and even within the incinerator, waste were not properly managed. Some were left out, it was not properly managed, and children within the area were at high risk of getting injury. Some were injured, and as a result of that, the facility became clean and the risk of injuries from medical waste were reduced. Then also because the environment is clean, low risk of occupational health hazards within the health facility, the staff morale also increased. And currently, as the Moro district, there is a project called result-based funding, which is being supported by Belgium Development Agency. And some of the indicators also include WASH and also fall within the indicators of WASH fit. So those facilities that properly implemented WASH fit, they managed to get more funds based on their performance. So it also improve the facility got more funds from the WASH as a result of implementation of the WASH fit tool. Then, because we also modified the tool to suit the control measures for COVID-19, the risk for COVID-19 was also reduced within those areas, those facilities. Then there was also improvement in institutional deliveries. In Uganda, we still have mothers who delivers from home by traditional birth attendants, and also they choose to go to other facilities that would be far. But because this facility improved as a result of the WashFit intervention, many mothers turn up for deliveries, and also it reduced that risk of maternal mortality. Next slide. Next slide, please. Yeah, we made some adaptation in our tool to suit the context of Uganda situation. And then what we did was to adjust the tool to suit the control measures for COVID-19. And then, Moro district, where this WashFit was being implemented, we don't produce radioactive waste because there's no hospital. It's just health centers, health posts in other countries, health centers which with a few low level of services, which is not advanced, and then also few staffs. So radioactive waste is never produced from those facilities. So we had to leave it out in our tool. And then Uganda also do have their quality for water. So we adapted the water quality testing using Uganda standard. And then also in those health facilities, they are in rural settings. I would say they don't have almost toilets. There are very few toilets. So we are also adapted it to latrine. And I am sure most people know the difference between the latrine and a toilet. Next slide, please. Then in the context of Omoro district, there should be more funding. As I told you, there are only 9 facilities that implemented the WashFit. So we are lobbying from the partners to support the district to cover all those facilities that are left. And then as a district, there's a district health development plan, the annual work plan. We are trying to incorporate this work plan of that will support us in implementation of WashFit. We want to include the plan for WashFit implementation in our district health department annual work plan. Next slide. Yeah, from the implementation of the WashFit, we observed that effective use of WashFit and effective leadership at health facility leads to increased demand for services from community, increase in staff morale, and it's also a tool that health facility managers should adapt to improve quality of care. So basically, that is what we observe from using WashFit, and we encourage other countries and other districts, probably within Uganda, to adopt this tool. Next slide, please. So basing on this, our implementation, the experience that we encounter with using WashFit, we recommend every country to bring on board all key actors to promote WashFit. And then we also encourage each country to adopt, adapt, and cascade WashFit implementation in all their health facilities, hospitals, if possible, health centers or health posts. And then WashFit should be integrated into the guidelines for WASH in healthcare facilities. Uganda is in the process of developing their guidelines for WASH in healthcare facilities. So WashFit should also be incorporated into that. Then it should be embedded, the indicators should be embedded in the health management information system and also reported quarterly to help the planners, the planners at the ministry, the planners at the district to support, to improve WASH in health facility. Then adaptation of this WashFit should be country specific. I mean, different countries have their different contexts, and therefore it should be adapted according to the situation of healthcare system in that particular country. Thank you for giving me this opportunity.
Thank you very much, Dennis. That's amazing. And it's great to see the lead that Uganda is taking to integrate WashFit into the national health system? Those indicators that you showed, the monitoring, that's solid progress on key outcomes, and what a difference you've shown that that's made for treatment-seeking behavior for things like antenatal care and birthing services. So thanks a lot for those recommendations and for that presentation. We're just now approaching the end of the hour. We maybe have time for one or two Q&A. I would like to turn right to the Swiss Water and Sanitation Consortium. We have Abubakar Ballo to share his experience from the point of view of Terre des Hommes in working with Mali and the Ministry of Health on using WashFit. So Abubakar, you've said that your approach is to first focus on awareness and training for the stakeholders on the WashFit process, and then to organize exchange visits between the WashFit teams of different health centers so they share learning, they learn about the 5-step process and how to make their improvement plans and take decisions accordingly. But my question for you is, you've been doing this for several years. So do you see any signs that WashFit teams can keep the WashFit process going on their own? For example, after you've closed your project and they continue on. Abubakar, what do you have to say?
Ok, merci tout le monde et merci beaucoup à l'OMS, UNICEF pour cette opportunité que vous nous offrez de partager nos expériences terrain sur WashFit. Effectivement, dans le cadre d'un de nos projets qui a pris fin en décembre 2020, malgré le contexte COVID-19 et puis la crise sécuritaire que traverse le pays, les comités WashFit dans 2 établissements de soins de santé que nous avons appuyés ont décidé par eux-mêmes, juste après le projet, de continuer à faire l'évaluation et à mettre à jour le plan d'amélioration. Donc en 2021, il y a une évaluation qui a pu être réalisée par ces comités-là. Et en 2022, déjà au premier trimestre, ils ont fait une première évaluation et comptent en faire une autre d'ici la fin de l'année. Donc en fonction de leur capacité, et ces comités ont décidé de contextualiser le processus. Ça consiste à quoi? Ça consiste à ne pas faire toute l'évaluation dans tous les domaines, mais seulement à prioriser les domaines dans lesquels il y a des efforts à faire. Donc, ils utilisent les supports papier du Caneva, du manuel WashFit OMS UNICEF. Donc, on a pu constater qu'après la fin du projet, beaucoup de progrès ont été faits par ces comités-là. Il y a par exemple un centre de santé qui a pu réaliser sur fonds propres une installation sanitaire améliorée d'une valeur d'environ $5 000. Donc, les 2 centres aussi ont électrifié les différentes unités. Ils ont mis en place un système d'épargne d'environ 10 000 francs CFA, environ $20 pour la maintenance des systèmes d'approvisionnement en eau. Donc, il y a aussi dans leur priorité budgétaire, ils ont décidé d'acheter continuellement tout ce qui est consommable d'hygiène et de payer la rémunération des techniciens de surface. Ce n'était pas le cas avant. Et autre chose aussi, c'est que les réunions WashFit sont désormais couplées aux réunions des comités de gestion des centres de santé. Donc, ça permet de faciliter la décision et de faire en sorte que tous les membres du comité soient informés de l'évolution du processus WashFit. Donc, la dernière supervision qui a été réalisée par la direction régionale de la santé il y a 3 mois et la visite aussi que l'équipe de Terre des Hommes, notamment le référent technique WASH, et moi-même avoir effectué il y a juste 4 semaines, ont permis de confirmer effectivement que la dynamique WashFit se poursuit très bien. Les comités sont en place et ils continuent à suivre l'évolution du processus. Donc, en conclusion, ma réponse est oui, effectivement, parce qu'on voit que malgré les défis qui sont liés à la mise en œuvre de WashFit, dans certains cas, il y a des signes positifs qui laissent entrevoir qu'il est bien possible par ces centres de santé de mettre en place le WashFit sans un appui externe. Merci beaucoup.
Thank you very much, Abubakar. That's very clear. Good signs that this process continues and it has its place and it's resonating strongly with community members to take those kinds of steps that you mentioned. We're really out of time, but maybe just one quick question to both of our presenters, Dr. Maruf and Mr. Dennis Okello. Maybe the question is, what would be the next priority step in Indonesia and in Uganda for implementing WashFit? And what is maybe one key piece of advice you'd like to share with others? Just in 1 minute, if each of you could respond to those 2 questions. One is, what's your next key step within your own Ministry of Health for WashFit? And what is a key piece of advice for those who are just starting off on their WashFit journey? Maybe we start with Dr. Maruf.
Yeah, thank you, John, for the question. I think very important in Indonesia to spread the implementation of WashFit in facilities, because more than 10,000 primary healthcare and also more than 3,000 hospital. So I think very important to implement the WashFit in many primary healthcare, also in the more than 10,000 facilities in Indonesia, health facilities in Indonesia. Besides, also we will conduct the training for health worker, yeah, because this very important to conduct training for the health worker, and also we must conduct the coordinating with the many sectors to prepare the primary healthcare to conduct the WashFit. I think like that, John. Thank you.
Thank you very much, Dr. Maruf. Dennis, same thing. What do you think? One piece of advice for those who are just starting on their WashFit journey.
Yeah, thank you, John. As a country, I told you Omoro and some few districts are just pilot districts, and the country has not yet fully adopted this WashFit tool. And based on the experience that I've observed, we shall ensure that the country fully adopted, and there will be a key stakeholders meeting in WASH, and then we shall start promoting WashFit. My message to the listener is that WashFit is a very important tool. It's properly developed. We use not to properly monitor our health WASH in health facility. It's the best tool that we can use, and it's a tool that can drive us to ensure that we really meet the goal of SDG. Thank you very much.
Thank you, Dennis and Dr. Maruf. Those are great closing remarks, and I think we're probably going to leave it here. It's really something how WashFit is bringing together community members, personnel, civil society actors, government decision makers, and getting us all involved in improving WASH and healthcare facilities. It's not just sparking conversations, it's leading to concrete action that shows real incremental improvements. So this is by no means the last WashFit webinar. We'll be organizing shorter, more focused webinars on particular themes, which may be also of interest to you. If we weren't able to get to all of your questions in the chat box, we will be coming out with an FAQ for WashFit and this new version. And we look forward to engaging with you in the future. I'd just like to thank again the organizers, UNICEF and WHO, for coming together and putting together this wonderful resource, as well as all of you who have contributed to the content of these new resources, and especially to our speakers from Indonesia, Uganda, and Mali. Have a wonderful day, everyone, and we'll see you soon.
Thank you. Bye-bye.
Au revoir. Merci.